Just last month in Experimental Hematology, there was a review paper titled Venetoclax, A New Wave in Hemato-Oncology, and now some new data from ASCO. So let's see how this wave is going to hit, shall we? I'm with Dr. Luciano Costa, who is an MD, PhD, and an associate professor at the University of Alabama in Birmingham. What is it about Venetoclax that makes it so interesting?
So Venetoclax is really the first mainstream now drug that works directly as a apoptosis promoter by inhibiting BCL2, which we have known for decades to be a mainstream anti-apoptotic molecule.
So why did it take so long to get to this part?
Very good question, and I think people have tried different approaches before to negate BCL2, but this has really been including interfering with message RNA for BCL2, but this is really the first one to be successful, as you said, and that speaks for the explosion of new molecules and new technologies that we had in the last decade in oncology. There were some precursor molecules that went really quite well in early clinical development, but they had some caveats because they were not as specific for BCL2.
Well, there were some signs of resistance.
That too, but there's some toxicity because of inhibition of BCXL, which is a similar molecule, also an anti-apoptotic molecule. But that one happens to be very crucial for megakaryocyte development. So those precursor molecules were met with quite a bit of thrombocytopenia that would really hinder the clinical development. Venetoclax is much more specific for BCL2 and overall is a very well tolerated agent. That has made its way in chronic lymphocytic leukemia. Now we're seeing really emerging data in other diseases, including acute myeloid leukemia, and of course, the one that is very close to my heart is multiple myeloma.
Now, in this case, what's the combination you're using and why?
Yeah. So in this particular study that we had the privilege of presenting at this year's ASCO meeting, we used a combination of Venetoclax with Carfilzomib, which is a second-generation proteasome inhibitor. There's several molecules on the BCL2 family. I mentioned BCXL, and there's MCL1. And it turns out the MCL1 is actually really the most relevant one in most multiple myeloma cases and most multiple myeloma cell lines. So BCL2 is not really a first thought when it comes to pro-apoptotic pathways in multiple myeloma, but it so happens that proteasome inhibitors, which are really a cornerstone of myeloma therapy, they do inhibit indirectly MCL1, and they do so by preventing the degradation at the proteasome level of NOXA, which is inhibitor itself of MCL1. So patients treated with proteasome inhibitors, they end up having essentially a downregulation, a degradation, or an inhibition of MCL1, making BCL2 more relevant, which really speaks for the rationale for the combination. There was prior experience with Venetoclax combined with bortezomib, which is the first-generation proteasome inhibitor, and that was quite successful. With very high response rates, including responses among patients who are previously proven to be bortezomib refractory. So it becomes kind of a natural next step to then combine Venetoclax with a better second-generation proteasome inhibitor, and that was the rationale for this study.
So describe the patients and what you found.
Yeah, the patient population were patients with relapsed refractory multiple myeloma with 1 to 3 prior lines of therapy. The median number of prior lines of therapy was 2. Those patients, actually the majority of the patients on the study were refractory to the last line of therapy. Half the patients were refractory to another proteasome inhibitor, for the most part bortezomib, and 2/3 of the patients were refractory to an immunomodulatory agent. So it's a very tough population, including some primary refractory patients. The study has accrued 42 patients, and we presented safety data for all 42. But because the study is ongoing, we presented efficacy data on a subset of 30 patients who had been enrolled more than 3 months prior to the data cutoff. And the study has had a first part, which is a dose finding, where we tested Venetoclax in combination with different doses and schedule of Carfilzomib that are used in clinical practice, and Carfilzomib at the dose of 70 milligrams per meter square once a week, which is really a new dose that is not on the label of Carfilzomib yet. But as we saw before on the Champion-1 study, and we saw this meeting with the Arrow study, is likely to become a mainstream way to use Carfilzomib. And among those 30 patients, we saw a very encouraging 83% response rate, with 57% being very good partial remissions or better. Of interest, we know that Venetoclax has been very active, including have a strong single agent activity among patients with 11-14 translocation. And although that was a group, we had 7 patients with such translocation, that was a group that did exceedingly well. All 7 patients respond, and 6 out of the 7 patients had VGPR or better. We also saw a very high, over 70% response rate in non-11-14 translocation patients. And as we know, many of those refractory patients, they carry high-risk chromosome abnormalities, and that's a very difficult population to treat. And we saw a very encouraging response rate north of 80% in both standard risk and high-risk cytogenetic abnormality subset of patients.
What about safety?
Overall is a little bit early to say. The study is ongoing, and we have 42 patients, but the safety profile seems very similar to what we have seen and what we expect for single-agent Carfilzomib. We had the common grade 2, grade 3 cytopenias, very uncommonly requiring any dose adjustments. We have some episodes of cardiovascular toxicity, just like as we see with single-agent Carfilzomib. And one thing that has been particular to Venetoclax in other uses, particularly in chronic lymphocytic leukemia, is the risk of tumor lysis syndrome. And that was seen very infrequently. We had one patient only, who was a patient with a high tumor burden in 11-14 translocation, who did develop tumor lysis syndrome, but that was promptly identified, managed, and the patient was able to continue therapy and went on to obtain a deep remission.
So overall, from what you've seen, would you say this is a new wave?
I think so. I think there is an ongoing study comparing bortezomib with bortezomib plus Venetoclax in a randomized fashion in patients with relapsed multiple myeloma. We are hopeful that study will give a more clear-cut and definitive answer to the question, does Venetoclax enhance proteasome inhibitors activity in multiple myeloma? And considering that most patients, or many patients that we see in our practice, are now bortezomib refractory because that drug is used almost ubiquitously in first-line therapy. Having solid data with on a population that is refractory and has been exposed to bortezomib before becomes very relevant. I think definitively the weekly dose of Carfilzomib seems to be the way forward, and it's great to have a combination that is safe and highly effective that builds upon that dose and schedule.
Are you really optimistic at this point with what you see?
You know, this is a tremendous time for the patients, first and foremost, and it's a very exciting time for us investigators. There are more avenues, more ideas, and more ways this could go that we really have the trials to address and we have the patients to fit. My personal goal is a little bit like pursuing the horizon. You can never reach, but you have a firm direction. I think my commitment, I think many of my colleagues, is to make sure we have a clinical trial for essentially every patient, because there are that many questions that need to be answered. We're seeing a revolution in terms of novel agents. In terms of novel combinations, there's an immunotherapy revolution that is working its way into multiple myeloma, as new approaches to cellular therapy with CAR T-cell and similars, but also antibody-drug conjugates, T-cell engager, monoclonal antibodies, and others that I think will continue to transform how we see this disease and how we manage this patient. So I couldn't be more excited, and I can't think of any other field or any other area of oncology where I would be happier at than I am now in multiple myeloma.